Dr. Jennings, and he recommended Dr. Jennings to us and referred him. And so we got in touch, and I'm very pleased that he was able to come and meet with us. I said in my email to all of you that Dr. Jennings is in Walnut Creek. He is not. He is in Alameda, California, which is, for all of us in the San Francisco Bay Area, we know where that is. It's just down the road, but it's not Walnut Creek. It's a different place. Dr. Jennings is a licensed dentist. You are still, correct?
Yes.
But he does not practice general dentistry. His focus for the last 40 years has been on facial pain and on causes of facial pain and jaw realignment. And we'll talk more to that. But I think we are all familiar with enough of the issues.
That's all I have to say. Thank you.
Now, somebody's got
on this topic.
is somebody talking, or you have some background noise on? No? All right. Well, I would like to ask you to all please mute while Dr. Jennings is talking, just so we don't get any interference. And unless anybody has any other thing they'd like to talk about before his presentation, I'm going to turn this over to Dr. Jennings. Please go right ahead. Now we can, I can put you on, full screen, or just leave you as a participant in the meeting. What would you prefer?
Anyway, anybody's fine. Yeah.
Okay. Okay. Well, if we need something else, let me know.
Okay. Well,
So take it away.
it's a pleasure being with your group. So my practice is limited to jaw orthopedics and medical management of a lot of different conditions. And about over 25, 30 years ago, I had a patient that I was treating for migraines post whiplash injury. Automobile whiplash injury. And a year into treatment, she confided in me that she hadn't been quite truthful when I started treatment on her, that she had an average, or she'd had 6 seizures a year all of her life until I put my mouthpiece in, and she'd gone a whole year without a seizure. And I was working with some doctors at the time on chronic fatigue and fibromyalgia in Sacramento. And one of them's a very, very bright guy. And he said, you changed her substance P levels. P is in Paul. And so a lot of you may not have heard about substance P, but substance P is the neurotransmitter associated with pain signals to the brain. Now, you poke the skin on somebody, there's an electrical signal goes locally and to the brain. And at the end of that electrical impulse, that nerve pumps substance P out into the body. And the reason you haven't heard about substance P is that there's no pharmaceutical compound that will block it. So there actually is one called aprepitant, but it's only approved to block it in conditions of severe nausea and vomiting after chemotherapy. My daughter's in med school on her way to becoming a neurologist. And in all of her years of training, she's finishing her 2nd year residency. In all of her years of training, she's only had 1 paragraph on substance P. And it was about how substance P modulates kidney filtration rates. So very obscure, not pain related at all. But that insight that I had 25 years ago allowed me to realize that I could lower substance P levels by fixing bites. And it's allowed me to look at a very broad spectrum of medical conditions that are substance P related. You might use AI sometime to look at all the different compounds that are substance P or diseases substance P related, but it's a very large number, including chronic pain and fibromyalgia. But it also includes gut motility issues. It's skin disorders, pigmentation, hyperpigmentation. It opens up cell membranes, opens up brain blood barrier and lets things into the brain that shouldn't be there. In the last 5 years, they figured out that substance P is a primary driver that's altering the dopamine levels in Parkinson's. And that means that the vast majority of Parkinson's cases are going to be bite problems. And the reason that bites have a high influence on substance P levels is that substance P comes from pain fibers, and over 2/3 of all the pain fibers in the body go to your jaw nerve, your trigeminal nerve. So this sensory zone here on your face is highly, highly innervated. That's why it's so painful to get your teeth worked on or get anything in your eye or get hit in the nose. Have an ear infection, all those things are very painful conditions, trigeminal neuralgia, right? But what's significant here is that what substance P does to the body when it goes up is that it opens up cell membranes and lowers the voltage potential on cells, and it makes cells all fire too easily. So that creates chronic pain conditions. So when your substance P is elevated, you're more prone to pain and hypermobility, movement disorders, and a broad spectrum of other conditions. Substance P is considered a major driver of heart disease, of seizures, of MS, of Alzheimer's, of cancer, lots and lots of different things. So you're welcome to go look at Ask AI about all the different illnesses linked to substance P, but the main message here is that substance P primarily comes from pain fibers, and 2/3 of all the pain fibers are in the jaw. And so it behooves us when we have a chronic pain condition to look at function within the jaw. And so function, the primary criteria of good function on the jaw, number one is that you open and close on a smooth arc, what they call a relaxed closing trajectory. And you can find that on someone by sticking a stick tongue blade or anything between their front teeth and having them close, open wide and close, and they'll automatically close to that relaxed position. And so that's how we find it clinically. And we can make appliances on that relaxed closing trajectory. And for the vast majority of humans, that closing trajectory is tip to tip, which by dental standards is considered abnormal. But functionally, for most people, it's ideal. And so when you wade into somebody and you're trying to find out where that jaw wants to be, it's 90+% of the time when their teeth are tip to tip, end on end, like all primitive humans used to be. These days, with our soft diets, jaws are receding and shrinking, more so with every generation. And so these days, most humans are born with a quite significantly compromised jaw relationship that is never diagnosed or picked up by your general dentist because they don't know how. They're not taught how to screen for jaw dysfunction. The TMJ joint is the responsibility of dentists, but you go to your dentist all your life and they never image it. It's a total neglect of duty on the whole profession to not be imaging and looking at jaw function and joint positioning. The second thing that's important on a good bite is that when you close up, that what touches first is your back molars. What happens on a good bite, you should close up and hit your back molars and then pivot around those back teeth to slightly get your front teeth together. And that pivoting around those high back teeth, microscopically high, allows the joints to get decompressed. If you close up and hit your front teeth first, then you automatically have to pull your jaw back and up to get away from those front teeth and to get your back teeth to touch so you can chew. And that compresses your jaw joints, excites all these pain fibers in your face and head region, and makes you more prone to chronic pain conditions of all sorts. As substance P levels get elevated and your firing potential of all the cells in your body drops, then that sets you up for what they would call like fibromyalgia, where people hurt all over, but the doctors can't find anything wrong with you, right? But it's often going to be in the bite because of that high concentration of pain fibers within your facial distribution. And so the other thing that I've learned over the years is that the techniques dentists are taught are not adequate for a high percentage of chronic pain patients. When dentists think you have a bad bite and they make you a splint, often a flat splint, and sometimes an anatomical splint that has little grooves in it, that doesn't work for about 50% of patients because because being off so long, they need more sensory guidance as to where to bite to allow the alignment sensors to relax. Your alignment sensors to your jaw muscles are the most important sensory cells in the whole body. They're called trigeminal proprioceptors. So your jaw alignment sensors, which are in your muscles and teeth and gums, go to a nucleus in the brain, and they are the only sensory cell bodies in your brain. All the sensory cell bodies for your eyes, ears, and skin are out in the ganglion, but your jaw alignment sensors are in the brain, in what they call the trigeminal mesencephalic nucleus. And that nucleus happens to be located in the brain immediately adjacent to your sympathetic ganglion. So when your bite is off a little bit, it puts you into sympathetic dominance, fight or flight, anxiety, and then it makes it really hard to be calm, cool, and collected anymore because you're revved up, you're in fight or flight mode, and it's hard to relax. And that in and by itself throws off a lot of normal mechanisms, healing mechanisms in the body when you go into sympathetic dominance. That neurological fact is also not known by the medical community. I've never had a single doctor bring that up to me or seen it in a single lecture that I've ever been to. So those importance of that massive sensory system, how those alignment sensor influence brain function, and that nucleus in the brain has a major influence on the brain stem, which is your center of movement origination. So there's multiple articles about how jaw misalignment causes movement disorders of all types, all the way from scoliosis to torticollis rhinitis to dystonia, Tourette's, Parkinson's, and the like. And heart irregularities, and I get those too, because the heartbeat also originates in the brainstem. But the dental profession, when they try treating these conditions, they'll often make their splints, put them in the mouth, and then they try equilibrating them with carbon paper. And in my practice, carbon paper doesn't work for a vast majority of my patients because they're way too hypersensitive. It'll work on a regular patient. We had a filling done, but in my practice, I have to use a polyvinyl siloxane. It's a silicone cream that we squirt on your teeth. You bite into it, it turns hard in 15 seconds, and we can hold it up to the light and look at how the teeth are touching. And it's probably about 30 times as accurate as carbon paper. And that a high percentage of my patients would never get well, but for the fact I use that silicone bite registration material. And dentists don't know to do that. They're not taught to do that in dental school, and there's very few of them that know to do that. The other thing, a lot of dental dysfunction is caused by bicuspid extraction therapy and orthodontics. When you pull teeth and close up those spaces, it locks the lower jaw back into the skull and makes your temporalis muscle work too hard, pulling the jaw back all the time. And this again gets excited, inflamed, and you go down a pain pathway. There's also a known connection between biting and body posture in general. As your jaw goes back, gets locked back into the skull, which is what happens as jaws degenerate or with bad orthodontics. The head goes into a forward posture. You get more curvature. You lose straightness of the spine. You start getting pronation of the feet. There's a study that they did on the Japanese have done 40 years of bite destruction on animals. They've done rats, dogs, monkeys, and every time they shorten the teeth on one side on an animal, they all get scoliosis. They become hypertonic on the opposite side of the body. That's rigid and frozen and stiff. And their legs on the opposite side of the body curl and bend. So they get scoliotic, scoliosis type curvature, not only in their legs, but then they get weak. It throws off their autonomic. They go into dysautonomia. And so they develop a lot of other medical conditions as a result of that bite being thrown off on them. This research has shown that the when you throw the bite off, they get scoliosis, but the medical community has never looked at that. I've never incorporated that knowledge. And this has been going on for over 40 years. So there's a vast amount of medical knowledge that never gets incorporated into our traditional pharmaceutical driven medical system. You know, if there's not a pill for it, they don't have a solution. But there's a lot that seems to be connected to jaw dysfunction. There was a book published in 1976 called The Dental Physician, recently republished. It's about $70 book. And it was by Alred Fonder out of Illinois. And he had a broad list of medical conditions that seemed to improve when he fixed bites. And he was doing all this back in the 1960s. There was also a dentist back in the 1930s doing this in Albuquerque by the name of Willie Mays. And Willie Mays and Janet Travell, who invented trigger point therapy, they both worked on John F. Kennedy and got John F. Kennedy a lot better after his World War II injuries. But there's been a lot of dentists doing this kind of work for many decades, but it never has really caught on the broad spectrum of looking at jaw orthopedics. There's now a lot more pressure with everybody looking at airway issues and sleep apnea to bring jaws forward more. When you bring the jaw forward, it brings the tongue with it, and that opens up the airway that's where the airway is obstructed in the majority of sleep apnea cases, is the tongue's back too far. But anyway, yeah, with chronic pain, you want to really look at jaw alignment. The screening tools that we use is we squirt them with polyvinyl siloxane, the silicone material, hold it up to the light and make sure that all their back teeth are coordinated and hitting properly. I had a Parkinson's patient that came in here about 2 months ago, and he wasn't even touching on one side. Right. So that's probably a cardinal reason that he developed Parkinson's. But you want to look and see that the teeth come together, which the dentists don't usually do. You'd want to get, with chronic pain, you want to get a three-dimensional x-ray, what they call a cone beam CT. And the cone beam gets both the airway, the TMJs, the sinuses, all the teeth, make sure there's no dental decay. I just had a young boy come in, 16, for a second opinion on ortho. And his orthodontist had taken a panoramic x-ray, but one sinus was completely occluded with a cyst and most likely an abscess tooth. He'd been to the ENT multiple times every year for the last 10 years, and nobody had ever imaged him or figured out that there was something plugging up one sinus. The orthodontist was looking just at the teeth and never saw the sinus issues. And so those three-dimensional cone beam CTs, they generally run about $350, but they're very valuable and show this structure at a much higher detail than most dentists are used to looking at it. Trying to think what else, but then so the solution for this is to get you into appliances that support your jaw where the muscles want it to be, and then to look in and see what kind of an orthodontic defect that jaw position created. And typically you have to widen the upper jaw a little bit because you brought a lower part of the lower jaw forward. And as the jaw comes forward, the socket has a slope. So as it comes forward, the back drops down. And so you got to grow the back teeth taller. And there's lots of ways to get those back teeth taller. In some cases, you have to put crowns on there, but the vast majority are treatable through a type of orthodontics. And you want to treat these cases non-surgically, orthodontically, and not prosthetically. There's a large group of dentists out there are taught to get the jaw in the right position and then crown everything, and that's about a $50,000 to $60,000 procedure. And it's a procedure. Fixing these things isn't a procedure; it's a process. No matter where you put that jaw in time, it's going to want to be a little bit different. So going in one fell swoop and making crowns and locking you into a position that's going to gradually migrate over time isn't a good idea. And so that's typically best treated with orthodontics, where you can keep modifying things a little bit over time if you need it. But then these cases, it's critical that they be maintained with a night appliance when they're done. And again, we use multiple types of appliances that index the upper jaw and lower jaw that maintains their jaw position even when they fall asleep and go unconscious, so that the lower jaw can't fall back when they're asleep and unconscious, which is typically what you find in snoring, right? When people fall asleep and lose muscle tone, the muscles relax and the jaw falls back and it shuts off their airway and they start snoring. There's my clinical experience is that I'm pretty effective at reversing or eliminating trigeminal neuralgia through my bite therapy. There's another dentist, Mike Harold Gelb, published a book many years ago, and he said the same thing in his book, that he was quite successful at reversing trigeminal neuralgia with jaw orthopedics versus the surgery. I usually get the ones where the surgery's failed, but they do still respond. So it's a neuroplasticity shift that you have to induce. And so it's a slow, gradual process of getting these people better and tougher and more stable. I have over 100 cases of grand mal seizures that have gone away. This seems to be very effective for seizures. And it's that substance P influencing brain function. There's another thing. The jaw nerve controls brain blood flow, what they call the trigeminal vascular system. And anytime patients have a cerebral vascular insufficiency problem, fainting spells, lightheadedness, dizziness, all those things, and you go to the doctor or the neurologist, they never, ever think about trigeminal vascular. Same thing with my daughter. I know this for a fact because she's in med school and doing her residency at Harvard, and she still hasn't heard anything about trigeminal vascular. They know nothing about screening for bite issues, and it's just never, ever brought up. I had a couple cases where one 50-year-old gentleman got a new partial made. 10 days later, he has what he thinks is a stroke, ends up in the emergency room, $15,000 worth of testing. He walks out of the emergency room perfectly fine. Nobody could figure out what happened. But the bite was bad on his partial, and it introduced a temporary ischemic attack and shut down his brain blood flow. And so he became paralyzed on half his body for a time. I had another 12-year-old girl, same thing. She has dental appliances. She lost her appliances, and about 8 days later, she had what they thought was a stroke also. Shut down blood supply to one side of her face. But there's different things like that the medical community don't know about, and so they're not dealing with a complete deck on ferreting out some of these pain issues and medical maladies, and they don't look at substance P. And so substance P, it'll often tie a broad spectrum of your medical conditions together. Substance P, where lower cell firing potential, that's what causes allergies and asthma, right? Your doctor, there's a reason that asthma is getting a lot worse, right? It's not so much the air pollutions as it's people's bites are getting worse and they're becoming more sensitive to inhalants. But allergies, same thing. A lot of my clients, as you fix the bites and get them better, they get better over time and their allergies go away. In the last 7-8 years, they found out that substance P is the primary driver of mood disorders. So they now believe that substance P is the primary driver of anger, violence, addiction, and depression. So it's considered a major modulator of mood and psychiatric disorders. But again, nobody's looking at substance P, nobody's chasing the bites, nobody's looking at where it's coming from, nobody's thinking very well. I went through a recent search on AI on the Parkinson's, and so AI told me something that would have taken me a long time to figure out, is that substance P is driving the Parkinson's. But when I ran my theory through there, it wouldn't agree with me. It said there was no evidence for what I was claiming, and so I had to go back and point out to them that what I was doing was lowering substance P levels and not blocking it. all the research is blocking substance P. And then AI came back and said, that's a game changer to be able to lower substance P and that I should be able to reverse Parkinson's then. But then it said there's no evidence that bite therapy can lower substance P. And I go, but there's this article which says that if you irritate the masseter muscle, it causes the whole brain to become inflamed, and that would spread through the whole body with elevated substance P. And AI came back and said, you're right. It said, you said you should be able to reverse Parkinson's. But so AI, that's the same problem with the medical community. They're all looking at what everybody else has known, and they're not very creative or very systems analysis on looking at some of these issues. So throw that out there for you, and hope some of you find that useful on trying to solve some of your own problems. And I'm more than glad to help and converse with anybody and anything they want. Go ahead.
Are you ready to take questions from
I am.
people now? Okay, well, I'll start, and I'm going to let you call on people, their names, and let you call on people when you see hands or whatever. But my
Okay.
question for you is, anybody doing any research right now about substance P and or jaw issues? I don't know of any pharmaceutical research that's being done right now, but that comes along always surprises me. So it may be something out there that I don't know anything about.
So there was a book published, I think, can't remember if it was last December or the year before, but it's on substance P, a big, really thick book, and it's about where they're at on substance P research in a broad spectrum of illnesses. I think there's about 30, 40 chapters, and every chapter is a different illness. I'd be glad to share that with the group. The name of the book is Substance P, From Cancer to Something Else. But it's about a $200 book, medical book. But yeah, there's very extensive substance P research going on. They're all looking. They know it's related to all these illnesses, and they're all looking for a substance P antagonist. And it's such an important molecule in the body. I think they just get way too many side effects when they start mucking with it. That it's hard for them to get anything approved. There is a recent new medication, I think, that Thomas told me about, that's for nausea. Yeah. So NK1 is the receptor for substance P. So that's the receptor, how they enable neurokinin 1 receptor. Substance P is a neurokinin. That's a neurotransmitter that does not have a reuptake mechanism, so it gets gradually degraded in the body and broken down that way. Did you have a question, Bill?
Sarah has a question. Oh, well, Bill had a question at first. Do you have?
Go ahead, Sarah.
You done well. Start with Bill.
Oh, Bill.
There he goes.
Thank you, Dr. Jennings. It was extremely interesting discussion. Half of them half the terminology I couldn't understand. It sounded like it was part of the dinosaur. But myself personally, I do have sleep apnea, a retainer, and a night guard, but I have not had any. I have Trigeminal for about 8 to 10 years, and since taking 2 medications, I have not had any, the electric shocks and things like this. But having a retainer and sleep apnea and the night guard, I guess does that so far I haven't had any any issues. So I should just maintain it then the way I'm.
So do you use a CPAP?
Yes, correct. Every night.
And so the night guard, does that fit on the upper jaw or lower jaw?
The night guard lower jaw.
So you might want to consider looking at a night guard that indexes the jaws together and keeps your jaw forward, and it would probably, in the very least, lower your pressure that you would need on your CPAP, but you run the possibility that you might be able to get off the CPAP.
Oh, really? Wow.
So dental appliances for sleep apnea are highly effective for mild and moderate sleep apnea.
Okay, well, I guess I have to look at the numbers and talk to the sleep apnea physician, see if it's mild or high. It's just, I remember they quickly, rushed me to get a CPAP because apparently I stopped breathing at a really high number per minute.
And
But
it was do you think it was central apnea or obstructive apnea? Did they say?
that I do not know.
Okay.
So,
Because you can have where the brain stops breathing, but most of it is obstructive, where the tongue is blocking the airway in the back.
oh, okay. Okay,
Yeah.
great. Okay, thank you, Dr. Jennings.
You're welcome.
I think Sarah was next.
Go ahead, Sarah.
Hi, this is the first meeting I've been to, and the reason I came back is because my neuralgia, trigeminal neuralgia has come back. I had surgery in 2018, so I've been fine for like 8 years, and now all of a sudden, after going to the dentist, I don't know if it has to do with it, but I kind of feel like it did. I had a crown replaced, and then like a couple months later, I have this flare up again. And I got surgery with Kaiser from Dr. Efron, and it seemed really successful. I've been really happy about it. But now it's like a nightmare because it came back. And the last time I got it, the first time, was also after I'd had a dental procedure. I do have a night guard. I had one for the bottom, but then I've gone to a new dentist now that I'm on Medicare, and they gave me an upper one. But I don't know. I do feel like something's going on with the teeth and that it has to do with the face. So, and anyway, I'm getting paranoid because I do not want to go back on that carbamazepine, which is what I was given, and it was horrible. So anyway, I don't know what exactly my question is, except that I'm glad to hear the dentist talk about this.
Does your bite feel different at all since you had the new crown made?
I don't know, maybe a little bit. But I think I don't always wear the night guard, and I'm pretty sure I'm grinding pretty hard at night.
So upper night guards aren't usually the best because they tend to push the lower jaw back. You want to make sure that that night guard is keeping at least where you're at or more forward than where you're at, because it could make any worse if it allows the lower jaw to go further back. And so generally we always make the night guards for the lower jaw and not the upper jaw.
Yeah, now my lower night guard doesn't fit anymore because they changed the the crown.
Right.
But anyway, I guess a question I have is, have you had success with working with people's jaw and having the trigeminal neuralgia stop flaring?
Many cases. Many cases.
And then also, is there a way to like get other dentists to be more educated about this? Because I don't know. I just haven't had a lot of good luck with dentists.
It's really hard. I did a class 2 months ago with UCLA TMJ department, and it was the most absurd class I've ever had. They were claiming that there's no connection at all between bites and anything. And I think they take that position to protect their ortho department. They don't want their ortho department to be liable for anything after they do the ortho. First, that would arise after the ortho. The University of Michigan got sued for $1 million on an ortho case and lost. And so I think UCLA is trying to prevent any lawsuits against their ortho department, but they just don't teach their dentists anything useful about how to treat these problems when they get out.
Yeah.
In the class, they spent 45 minutes on pharmaceutical management of migraines, of headaches. And at the end of the 45 minutes, I asked them, well, do you ever check the bites? And they go, no, we don't check the bites on headache patients.
Yeah, well, that's unfortunate.
Yeah.
That seems,
so it is tough to get.
That seems sort of self-evident.
And so that's what I would think. Like, what in the world? Yeah. Yeah.
Okay, thanks, Sarah. Judy, you were next.
Thank you. That was amazing. I am just blown away. I wish that all dentists knew what you know. And,
Uh,
yeah, you're the first person who ever mentioned the vascular effects of the trigeminal nerve and injury. I have been complaining to my dentist and neurologist for a while that I can hear my blood pulsing in my head. And I also have pulsatile tinnitus. And I looked it up online and I saw that the trigeminal nerve does partially control cerebral blood flow.
yeah.
So I went to a headache neurologist, and she just said to me, well, because I have a history of migraines. And I said to her, I don't get migraines anymore. And she said, yes, but because you had a history of migraines, you have a migraine brain. And that's the reason for all of your problems.
Wow.
And so she said, go home and look it up. So that was all she told me. But I mean, you did confirm to me that it's the trigeminal nerve that's causing this
Yeah.
pulsing in my head. Is that dangerous whenever you have too much cerebral blood pressure?
I don't think the trigeminal would cause too much. It could alter intracranial pressure, but I don't think it would cause too much blood pressure in the brain. It could cause too little, it could constrict it, but I think if it dilated all the way, it wouldn't create too much. But it may be a constriction. The reason you're getting the pulsatile noise because it's happened to go through smaller areas, right? But most likely you developed a hypersensitivity syndrome in that area where your hearing is more acute than it should be. All right, that's most likely that is in tinnitus. I think most cases of tinnitus are from the substance P levels going up, and it makes the hearing more acute, and so you hear things that shouldn't be there, like the ringing, right?
So when I go to shows, movies, or anything, I stuff cotton in my ears because it is so loud and painful and annoying to me.
So so besides that, do you have any other medical issues, inflammatory conditions?
I have scoliosis and some back issues too. And I have a dental mistake. A dentist left etching acid on tooth number 19, and it caused damage in my inferior alveolar nerve, and then it spread to all three branches of my trigeminal nerve. So I have to say, in the 5 years that I've had this, the pain has improved a great deal, but I do still have this pulsing in my head and headaches, and I do feel it in the back of my head too. Sometimes my ear still gets hot, and I do still have some pain, but it's vastly improved, and I'm very grateful for that.
How the bites can influence things, like a case I had in today, and this lady had chronic severe neck pain, and they couldn't find anything wrong with her neck. But as we fixed her bites, she's been able to reduce her gabapentin from 1,800 milligrams a day to 200. Right, and so she thinks she'll eventually be able to get off it altogether. But
And do you fix the bite with the stents, mouth
splints,
cords, or do you do braces?
we fix it with removable appliances. In most cases, you got to grow the teeth taller, and braces ties all the teeth together, and they won't grow taller. So you have to bootstrap the bite to a certain height and not cover certain teeth, and let those teeth grow taller, and then switch and let the other ones grow taller later.
Does that expose more of the gums though?
Now,
And
the bone bends.
the dentin, I mean, at the top.
The bone bends and pushes those teeth up taller. Teeth are always trying to stay in touch with each other, and so there's a natural movement for teeth is to erupt.
Okay. Okay.
Okay, Anna Marie, you were the next one.
Okay, thank you. Thank you. Hi, doctor. How are you tonight?
I'm good.
Good. I almost 4 years ago, I had a dental crown put in my mouth, and I had like right-sided pain in my mouth, and I was getting headaches, and my tooth was throbbing, it was all the right side. And the dentist told me to come back in a week, and she filed my teeth so rigorously that now I have bilateral trigeminal neuropathy. I'm in a lot of pain still. I take Botox every 12 weeks. I'm started Vyepti. I'm on gabapentin, cyclobenzaprine, Cymbalta. I have gut problems, and yeah, it's affected the three branches of my trigeminal nerves, and I'm tired of taking medications and going for treatment. I'm depressed. And it's funny because about a week and a half ago, I was measured for a night guard, and I didn't know. I wish I would have seen you before I had done it, but they had like a device where it was sort of like an like a gun, like an X-ray gun or something, and she showed me. It was pretty cool. It was like pretty high tech, and she did my teeth, and then she showed me on the screen.
Oh, she scans it,
like
a digital scan.
yeah. So my question to you is, like, I live in North Carolina. Sorry, my memory's going too with the chronic everything. I'm never not in pain. It's just I'm exhausted. Even sleeping, I wake up in pain. So
Wow.
I have to wake up a lot, to
So there's an organization you might look called the International College of Craniomandibular Orthopedics, ICCMO.org. ICCMO.org. And see
ICC.mo.
see if they have any members near you in that organization.
Okay. So is there help for me? I mean, I'm trying to do everything I can, but before this happened, I was basically healthy. I wasn't on any medication. Now I've tried at least, 25 plus medications, and it's just.
Yeah, it's really hard to get medications to help when your substance P levels are so elevated. Right.
Yeah. So what do you suggest? Just checking out this organization and maybe.
Yeah, check out and see if there's somebody local in your
Okay.
neighborhood that belongs to them.
Okay, thank you, Doctor.
I did a course in right just over the border into South Carolina about 15 years ago, and they actually had a really good group of dentists that were pretty educated on TMJ in the area at the time.
Oh. You don't remember the names of the.
I don't.
Okay.
I don't
Okay.
recall it's been so long ago. I don't recall.
Gotcha. All right. Thank you, Doctor. God bless you. Thank you for your help.
You can always email me. And I'd be glad to help you on that finding somebody.
Okay. Thank you so much. I do appreciate your help.
You're welcome.
Thank
Hey,
you.
Stacy, I think you were next.
Hi there. Yes, I'm Stacy. I'm a volunteer with the Facial Pain Association, and I actually live in Southern California. I'm in Los Angeles.
Wow.
Please forgive me, doctor. I wasn't really here for most of the meeting. I intended to be, but my cat had other plans. But I have this jaw device. Are you familiar with the Gentle Jaw that treats arthritis of the jaw?
No. What's the name of it?
Gentle Jaw. Here, I'm gonna take off my background and show the group here. I had seen an orofacial pain specialist where I live here in LA, and just by coincidence, he created this device called the Gentle Jaw, which helps treat arthritis of the jaw. He sent me to get a cone beam CT of my jaw, and so he determined that I had severe osteoarthritis on the side that I was having all the pain. Sorry, just give me a second here. I'm gonna undo my background so you can see this device.
And do you wear this device all the time or part
It's not something that you wear. It actually, so this is the package,
Okay.
Gentle Jaw. And it comes in 3 sizes, small, medium, and large. So this is, I don't know if you can tell by the camera, this is the smallest one.
Okay.
This is the biggest one. So it has one ridge on the bottom that rests on your bottom teeth.
Okay.
And then it's got multiple ridges on the top here, and you
Okay.
use it to stretch your jaw for however far it's comfortable.
Yeah.
Like that. And it has the instructions. He instructed me to do it 30 seconds, 4 times a day. And I definitely noticed a difference after a few weeks. So if anybody here in the group, if you've been diagnosed with arthritis of your jaw, definitely check out this. He sells it on Amazon and he sells it on his website. If you just Google gentle jaw,
Cool.
and it has the whole package with the 3 sizes and the instructions.
Cool. Very good.
Thanks, Stacy.
Yep.
Ellen, you had a question?
Yeah, at first I want to say thank you so much for being with us tonight. So I have a couple questions for you. Are you familiar with there's Daniel and Ivan Lapidus in San Luis Obispo? Do those ring any bells to you?
Does not.
Okay, because they're supposed to be oral facial pain people,
Okay.
but I kind of felt like they were a money grab, so I didn't go to them. But so you talked about the dysautonomia, which
Uh-huh.
I've been diagnosed with I believe I do have. I also have HOCM, hypertrophic cardiomyopathy, obstruction in my heart. So
Okay.
I've got a few little things along with the TN, but so I'm in like the Santa Maria area, but are you seeing new patients that you can consult with or?
I do.
Okay, because I'm thinking it might be worth a trip for me to get up there at some point to see, because none of the neurologists know what you know. And I have a mouth guard, but I don't know if it's helping or hurting. And to be honest with you, I'm afraid to ask for a new one with a dentist here because I don't know, this area, they're not that strong and I don't really trust anybody. So, but yeah, so what, like, I mean, would I have to be there multiple days or how would that work?
So I do a very large amount of fly-in clientele.
Mhm,
We get them from all over the United States and around the world.
mhm.
And so typically we have them in one day and we have their appliances ready the next day.
Okay,
And then we have them sometimes stay one more day,
okay,
just to make
okay.
sure everything's working well for them.
Okay.
But yeah, you might want to call and talk because the mouthpiece might get you out of pain, but then it creates a bite defect, and so it's a involved process to treat it properly and completely.
Mhm,
And getting something, I mean, it would be nice to know it gets you out of pain. It's part of the diagnosis is
Right.
getting you out of pain, right? And you know you did the right thing.
Right.
But again, it's going to leave you with a bite defect that you got to figure out how to think about how you're going to fix that, or you may be in as bad a condition as before in time.
Okay. Okay. The other thing I want to say too, I went to a dentist and he did put like some paper thing to test to see if my teeth, but then he like did some grinding. I don't think it really made it worse, but it certainly didn't make it better. So it's kind of like he pardon my language, half-assed knew what he was doing.
Right.
And then he sent me to the endodontist. And he said that, because I thought for sure I needed a crown or a root canal, and he said this is an oral facial problem. So,
Yeah.
okay.
Good.
So what you're telling me is if I come, it could cause me more problem than what I already have, or?
Well, now you got to realize that if you do it, it's a commitment. It's a long haul thing, and it's not a matter of
Okay.
just coming, getting an appliance, and being done.
Okay.
Yeah.
Okay.
So no matter when I give a patient a mouthpiece,
Mhm.
in about 4 weeks, their muscles have relaxed and changed, and their jaw wants to be in a different position. And for somebody in chronic pain that's
Mhm.
very hypersensitive, that slight shift the pain will come back on them in time. So you
Okay.
have to keep adjusting it over a matter of weeks and months before that jaw finally stabilizes.
Okay. All
Yeah.
right. Okay.
So
Thank you.
Thomas,
Well, the typically procedures can precipitate a central sensitization where the brain becomes very hypersensitized, and then it's a very slow, arduous process to reverse that hypersensitization in the brain. But it usually is possible to reverse that if you do sustained musculoskeletal balancing over an extended period of time. The body will typically calm down. Yes. That's what I generally do by getting the bite orthopedically aligned and maintaining that there both day and at night too. 40% of my patients don't do well until they get into a specialized night appliance that won't let their jaw displace when they're unconscious. And a lot of dentists don't know that either. They tend to make you just a mouth guard, and they think that lower upper mouth guard is going to work both when you're conscious and unconscious. And oftentimes people need a different appliance for when they're conscious versus unconscious.
Susan, with your group, and some of these folks here may be part of your group, and some of them came with, whoops, what happened to Judy? There's Judy. Some of these people I think came from Judy's group. Do you hear much of this from your people who in the dental group, that they've had some of these same experiences or same injuries or same solutions?
Well, most of the people in my group, they, have all gone to a dentist. Some had pain before. Others, like myself, didn't have any pain. And we're all, heavily medicated. There's no solution for us. Typical trigeminal neuralgia. And, you've got a blood vessel on the nerve. The MVD surgery is pretty darn successful. Some people have to have repeats, but a lot of people don't. But for us, we're in this gray area. Or this donut hole. There's nothing for us. The constant burning pain. Unless what you're saying is a dental appliance. Now I have one, but it's upper because that's where my pain is. And I put a magic mouthwash solution in it to try to dampen the burning pain at night and sometimes during the day, if I'm home by myself. But other than that, gabapentin, Lyrica, carbamazepine, well, that's more for an MVD situation, but we're just all heavily medicated and we don't know what to do.
And have they ever done a CBCT on you?
That was one of the first things that I had done.
And so when you bite right now, how much overbite do you have?
I'm getting to where I can't even feel my teeth. I don't have much of an overbite. I had braces when I was a kid.
Did they pull teeth on you?
Yep.
Yeah, there's the problem.
From when I was a kid?
Yeah. Yeah, pulling those teeth would definitely force your jaw into a tense muscular position.
Well, now you're freaking me out because my 12-year-old grandson just had teeth pulled in braces.
Yeah.
But now Susan,
you too, Thomas?
Susan, you definitely had an injury that caused your facial pain.
Because I have receding gums from probably braces and getting older. I had a periodontist that did a gum rescission. So he took a graft off the roof of my mouth and put it on the side of my mouth. And I've never, and the next day I woke up and I was so badly bruised and swollen that my neighbors thought my boyfriend had beat me up.
So,
And I've never been out of pain.
so there's some really good research done by a dentist from San Francisco by the name of Gene McCoy.
Oh, I've never heard of him. I've been to probably 50 or 60 doctors.
Write that down.
Gene McCoy.
Gene McCoy. So Gene McCoy and his research showed that the predominant cause of gum recession is that teeth aren't quite precisely aligned. And so on a normal tooth, upper teeth hang a half a tooth out over your bottom teeth. And so the inside peak hits the middle of your lower and the outside peak hits the middle of your upper. And so when teeth are lined up so that they're not quite peak to valley, every time you bite down, it makes that tooth flex a little bit and it causes the gums to recede.
Huh.
And so
Interesting.
I would suspect that the ortho didn't quite leave you quite precisely aligned. And that's why you get in the gum recession and why you'd be prone to the TN problem.
Interesting. But I have no pain on the other side. And I didn't do we were supposed to do the next side, my right side, the following week. And I've never had it. And that was 12 years ago. And I don't have any pain there.
Yeah, but I don't know that I've ever had a TN case where it was on both sides.
There are some people it's bilateral.
Yeah, I don't think I've ever had one though.
I think it was a needle stick. It was a bad needle. And I've read peer-reviewed articles about that. That's just how I feel. I mean, that makes sense to how I feel. I feel like I was stabbed in my upper jaw.
Yeah. So
Now,
you might have somebody squirt you with that silicone material sometime and see how precisely those teeth are aligned. It's too easy to do. Yeah.
So easy to do, and probably an appliance.
Well, you would, yeah, you got to find you got to find something wrong with you before you make an appliance. You got to figure out what you're going to fix, what you think. But just having a dentist squirt you and holding that silicone material up to the light and seeing if the peaks and valleys are where they should be is really easy to do.
And that'd be you.
Well, or somebody, but it's too easy it's something that dentists should be doing on every patient, but they don't do it on anybody,
No.
And what is that? What is that material called again?
It's called polyvinyl siloxane.
Poly.
PVS. PV is in Victor, S is in Sam. PVS bite registration.
Okay.
I've even gone to the University of Pacific in the city. That's where I go now because I don't trust dentists anymore. And the young kids seem to know a little bit more than, most of the older dentists that I've gone to in the Bay Area.
So the Council on Dental Education, which is what certifies dental schools, now mandates since 2022 that all new dental students learn about TMJ. But
we're not talking about TN. I'm talking about TN.
Yeah, but if they're going to be screening you for a bite dysfunction, and so they're learning a little bit more about bite dysfunction. There'd be something perpetuating your TN, something that's exciting that trigeminal nerve. That it's your trigeminal nerve where the pain is, and so the question is why is that nerve excited?
Right.
And it's most likely a functional defect in your bite. That's it. Maybe not necessarily. It could be a abscess tooth or something like that, but it's most likely a
even though I didn't have that before I went to the dentist.
Yes, even before. So what you find is that people have a bad bite all their life, and they get migrating illness. You know, they'll have allergies when they're younger. You know, as they get older, they'll get more migraines. They get gastrointestinal problems. As they get older, you start seeing more autoimmune disorders. You get older, you see more cognitive brain stuff. And so that elevated substance P keeps morphing their whole life into different illnesses. 9 out of 10 top 10 causes of death in the United States are substance P related disorders.
Huh.
And nobody's saying anything. That's heart disease, right? That's cancer. That's kidney failure. That's suicide. All right, you go down the list. And so substance P is a major, major medical issue. And bites are degenerating, getting worse with every generation, and nobody's calling it.
Hmm.
There's a book called what's the name of this book? Orthodontist Contribution, Anthropologist Contribution to the Orthodontic Diagnosis. And it's about studies around the world showing that every generation of children are significantly worse than their parents on their bite structure.
So it's just an evolution thing, and we're not dealing with it.
Exactly.
Judy, did you have another question?
I apologize, but I do have another question. I'm
No
always trying
apologies
to,
necessary.
No, you only get one.
oh dear. I'm always trying to learn though, and I did listen to a speaker last night from the Boston group, Ronald Coolidge,
Yes.
the mental health. And he made a statement that if you have one pain site, you have a very good chance of getting another one or two pain disorders. And
Yeah, there you
afterwards, I thought, why didn't I ask him why? What's the mechanism behind that? But Dr. Jennings, would you say that it is substance P or bite malocclusion?
So as your substance P levels go up, it's systemically through the whole body, lowers the firing potential of all cells. All cells fire too easy. Substance P is considered a major neurosecretory modulator. It also throws off hormone levels, tends to put you into estrogen dominance, right? And so when you have one pain condition and your substance P levels are elevated, it lowers the potential of all cells in your body to fire easily and create another pain pattern. So pain begets pain. If you have pain, it'll make other areas of your body also more prone to pain.
Thank you.
And that also because the pain neurotransmitter, the substance P, has so many other biological, it's such a strong biological modulator, it makes you prone to a lot of other medical disorders like eczema, psoriasis, acne, I have a number of patients that are in pain that have excessive freckling. And I have many of those cases that by the time I finish their treatment, their freckles have gone away. And they've been there their whole life.
Wow. Wow.
Right? But
I've
if you
heard
go,
people in the groups talk about weird rashes, just
Yeah.
developing weird rashes for no reason at
yeah,
all.
so it's all substance P driven.
Hmm.
Yeah.
Hmm.
Yeah.
Amazing.
And so
Cytokines, they're related to cytokines, right?
substance P is what makes the body produce cytokines.
Mhm.
Substance P, when it attaches to mast cells, cause histamine release. So the mast cell syndrome is actually a substance P problem. Right, that's also what you see. But people with bite dysfunction, as the substance P goes up, they develop a generalized hypersensitivity syndrome. My typical patient is more sensitive to noise and to light and to hot and to cold and to food and to drugs and to stress. As that substance P goes up, they're more prone to reactivity with any sensory input. Substance P is all about the sensory system, and the body runs on sensory input, but medicine does not have a sensory theory of illness. Nobody ever assays your sensory system as to whether it's hyperactive or not. right? And so there's this huge spectrum of medical dysfunction that's from the sensory being overstimulated, right? Too much noise, too much hot, too much cold, it'll all make you sick, right? Too much vibration, it can all make you sick. And we're just not appreciative of the sensory input. And we don't look at the medical history collectively in mass. You know, my patients, I can go through and they've got 10 different substance P conditions all going on, or a history of all of them having gone at one point. And so it kind of jumps out at you when you know to look for all those inflammatory conditions. You know, they had a history of headaches. When substance P opens up cell membranes, it allows the inside of the cell to leak out. And that's what we call inflammation. But what happens is the calcium outside the cell, which is not supposed to get in, goes into the cell. And that's throws off calcium metabolism. So now we ended up with osteopenia, osteoporosis, hardening of the arteries, you know, tumors, you know, or osteoarthritis and other things like that when calcium is not on the right side of the cell. But
Stacy, you had another question? I'm sorry, doctor.
But substance P is considered a major immune modulator of the bad cytokines. So substance P makes the body produce the cytokines, and substance P attacks mast cells, causing histamine release. So substance P is in the equation that generates both of those. Yeah.
So Stacy,
Dr.
you had a
Jennings?
question?
Yeah, I'm sorry if I missed it from your presentation earlier. How does one get checked for the substance P levels?
So there's only one company that tests substance P level, is Quest. That's about a $250 test. Medicare often covers it, but I'm not so sure that they do a very good job at measuring it. I've had a number of cases come back and they say non-detectable levels in people that are in chronic pain. And so that's just not believable. They also, when they set their norm by their own admission, it's totally wrong. I talked to them here probably 10 or 15 years ago when they used to do their processing in Santa Barbara, and they came up with their norm of 1,700 or less by measuring 30 of their employees. And of those 30 employees, one came in at 2,800 and one came in at 1,800, and all the rest were less than 1,000. And they set the level at 1,700. I asked them for their latest 100 tests, and they sent me their latest 50 tests. And these were all sick people, but not a single one of them was over 1,000. And so it's clearly, I think that norm should be less than 250, and they tell you that norm is less than 1,700 on their scale. So I have doubts as to how well they're doing that test and how accurate it is. But that's where you do get it measured. That's a only place to get it measured.
So you'll probably laugh at me if I ask, does Kaiser do the test?
Susan, you know the answer to that question. Well, does anybody else have a question for Dr. Jennings?
I have a couple questions.
Oh, Ellen has her hands up too. I'm sorry, Kathy Jo, can you hang on for a sec? I'll get back to you. What happened to Ellen?
I'm here. I just wanted to see if the doctor knows anybody in the Santa Barbara area that he could recommend that might be knowledgeable.
I don't. Let me, if you email me, I'll be glad to look and see if I can find somebody for you.
Okay. Are you going to give us your email? Or?
Yeah.
Yes.
Okay, great. Thank you so much again.
You're welcome.
Okay.
Why don't you give us your email right now while everybody is here?
Yeah, it's DEJDDS, David Edward Jones, David Sam at, let's send it to my Gmail at gmail.com.
Okay.
DEJDDS@gmail.com.
Okay, now, and so, oops, who was it? I'm losing it. Was it Kathy Jo? Yes.
Hello, good evening, everybody. Thank you, doctor, for coming out and sharing.
You're welcome.
I'll tell you a bit about my story. I had a clostomia removed from my ear, and that's what triggered my neuralgia. And also was born with a speech impediment and a hearing loss. So I went to speech therapy, and I had the MVD surgery, and the doctor says, I think you were born with this. Now, what my problem is when I talk a lot, I get a flare. When I eat, I get a flare. I'm having Botox done now. I wear the CPAP, but the straps seem like they're hurting me. And is there any jaw exercises that we could do? When I talk early in the morning, it seems like I get a trigger.
So jaw exercise, they have some of those, what they call it, hard rubber things that you chew on. I'm trying to think what they call those. But those might help building you up. But so substance P levels naturally and normally become more elevated as you chew. And so when you chew, your substance P level spikes, and that turns on gut motility, it turns on the smooth muscles in the gut. And so the gut starts churning and processing what you sent down there. So it's a natural process for substance P levels to be elevated shortly after eating. And probably the same thing with talking. Using those jaw muscles would make your substance P levels go up.
Brushing teeth?
Yeah, so again, you might want to look at, you have someone check your bite and see if it's as good as they can get it.
I do wear the bottom guard. I have a head and pain doctor here in Roseville that's given me Botox shots, and he gave me the bottom piece for my mouth that I sleep with.
Does that help?
It seems to when I wear it. Shame on me. Okay. I get to be more compliant and wear it more. Let's see if it makes a difference. But even talking flares me. And you're saying the several P level. Can my primary doctor do that?
Yes.
And
Yeah.
you say Quest Lab is the lab that processes it?
Yes. Yeah. Quest. Yeah.
Quest.
But the fact that you had a speech problem when you were younger would point to would strongly suggest that there was bite dysfunction even then.
My dentist says my bite is all over.
It's all over the place.
All over the place.
Yeah. Yeah, that's so when people don't have a good bite, the jaw keeps moving, trying to find a place where it is good. And so the bite moves all over the place when it doesn't have a good home spot to go to.
Okay.
You bite in a different spot every time because no matter where you bite, it doesn't quite fit right.
It's pretty good as long as I'm being aware of it, conscious, bite right, Kathy. And I try not to, I relax my jaw a lot because if I bite and smile and talk, I get, what's the word, sore. It's better for me just frowning. The muscles here in the face get really tight. And I'm swollen on one side. But the teeth, the dentist is okay, but I think this is coming from my ear, but I do have teeth issues too. And it was very interesting what you shared tonight about our bite, about the substance P. And how do you feel about Botox?
Botox, it works on the short term, but the problem with it is it only lasts about 90 days and you got to redo it again. So it doesn't really fix anything, but it'll help a lot of times on the short term.
What about acupuncture?
Acupuncture lowers substance P levels.
Lower?
Yeah, acupuncture helps. Cayenne pepper depletes substance P out of the body.
Oh.
So substance P is the primary herb. There's also another herb, Rehmannia, that most people haven't heard of. It's REHMANIA. Mannia, Romania. And there's some studies where it was highly effective at lowering substance P levels also.
Just it's legal now. I'm gonna put it out there. What about THC and CBD?
So CBD does the opposite of substance P. CBD stabilizes cell membranes, and so it's very helpful in a lot of ailments.
And what about the THC?
I don't have any experience with it, knowing how it works on cell membranes.
But the CBD, then what's the other one? CBG?
Don't know that one either. I haven't looked at that one up.
But CBD does help.
Does help, yeah.
And does that also help for the inflammation?
Yes. Yeah.
It's kind of like
you stabilize cell membranes, and it's going to help inflammation.
does cell membranes go a lot with their diet?
There are a number of supplements like vitamin E that also has an influence on cell membrane levels. So there are things you can do dietarily that also help to stabilize and counter the negative effects of substance P.
High protein?
So fat cells make more substance P than other cells in your body. So being obese does aggravate substance P conditions.
Okay.
So being on a high protein diet and getting more lean would typically help.
Fish,
Uh-huh.
less fat, inflammation diet.
Yeah. Mm-hmm. And yep.
Or what do you call it? A Mediterranean diet?
Yeah. Anti-inflammatory diets.
Anti-inflammatory. We are what we eat, huh?
Yeah.
Well,
Kathy
thank you so
Jo,
much.
You're welcome.
I wanted to mention to Kathy Jo, I have gone for acupuncture and I found acupuncture has been the most helpful in relieving facial pain. My acupuncturist is in Los Angeles, but he's actually going to be speaking at one of the groups next Saturday, the Orange County group. He's going to be the guest speaker. I'm going to send Terry and all the other group leaders the email with the Zoom information link so that if you're on their list, you'll get the email about it. It's next Saturday, the 25th at 3 p.m.
Wonderful. Thank you. I need all the help I can get. Okay.
Well,
And it's also on the facepain.org website.
Mm-hmm.
Several people in our group have had really good success with acupuncture. I'm doing it right now. And how many times did you go? How many sessions did you have, Stacy?
Well, I still go for like touch up because my shoulders are still not in good position, but putting the strain on my shoulders and my neck.
Uh-huh.
But truthfully, he had me come once a week for the first month, and after 3 sessions, the pain was pretty much gone. But it was once a week for 3 weeks straight, really like getting it hard. And at that time, I was also doing the gentle jaw exercises daily. I was he started me on this Chinese herbs for the anti-inflammatory. So I think just doing so much all at once, that quick really helped.
Yeah.
The other things that I find really helpful too on a number of patients is the LED lights, the red light therapy, right? You can get those pads from Amazon for in the neighborhood of $40 to $60. And the other thing that I think anybody with chronic pain, I think that everybody should have around their house for in their first aid kit is lidoderm patches. Those are very, very helpful, and particularly on breakthrough pain conditions.
What can you put on your face for pain?
Yeah, you can put those on your face.
You can do, yeah.
The lidocaine patches?
Uh-huh.
Wow. I've used some CBD THC creams, and it's got a burn. It's got cayenne pepper in it and a few other things, and coconut oil. And it gives me a burn, and when it burns, it takes away the pain. Seems like it's fighting those receptors and then it goes away.
Well, cool.
And if I get really bad, I do biofreeze, okay?
Mhm.
If I
Well,
don't have
Dr. Jennings,
anything.
Dr. Jennings, I want you to know I really appreciate your being with this group tonight. And
You're welcome.
we had a pretty good group. It looks like we lost a lot of the East Coast people, but they usually can't quite hang on till the end. But I really do appreciate it. I know people, Thomas has a question here too. We're going to kind of wrap it up, but Thomas, go ahead if you have a question for Dr. Jennings.
Yeah, let me see. Oh, yeah, I can do that. Yep. Yep. So the one slide is just a little visual about substance P, about the C fibers, the pain fibers in the body. And the other one is a sensory homunculus showing how the pain fibers are allocated to the brain. And then I was going to show some TMJ pictures, just show you what can happen in the jaw joints.
Were those slides in your YouTube presentation?
Probably, yes.
Because that's another place people can go. Find you can, and it's easy search. You can just search Dr. Jennings' name on YouTube, and you can
Okay.
find his presentation. It's not hard to find, and that's a longer presentation, a little more in depth. And if you're interested in knowing more about this, that's a place to start.
And Thomas, where are you going to upload the YouTube video of tonight? Okay, cool. Functional dental medicine, because I have some people that were asking if this was going to be taped tonight. So I'll tell them to go to your site. Yeah, cool. Thank you so much.
And thank you for recording it, Thomas.
Yes.
Okay, it's been a very good group. I'm very glad to see you all. I'm very pleased to have met Dr. Jennings, and
Same here.
thank you so much for being here tonight. I really do appreciate it. Any last minute questions or? No?
All right.
Thank you so
Thank
much.
you.
We'll
Been a pleasure.
be here again
Thank
the
you.
third
Thank
Wednesday
you.
of next month,
All righty.
and we can talk more about Dr.
Thank you.
Jennings if you'd
You're
like to.
welcome.
Thank you
Thank
very
you.
much. Okay, good night, people.
Good night.
Good night.
Night.
Oh, Terry.
Mm-hmm.
Oh, hi. Yes, I don't think I'm in your email list, so I wonder, can you give me the email for Dr. Jennings?
Dr. Jennings, I put it on the screen. Dr. Jennings' email is dejdds@gmail.com.
DEJ
DDS
DDS
@gmail.com.
@gmail.com. Okay, thank you so much.
Okay. All right. Good night. Thanks,
night.
Thomas, for recommending Dr. Jennings.